So I want to talk to you today about ultrasound and resuscitation, and specifically cardiac arrest, something I'm really passionate about. And here's why. I did my emergency medicine residency at Kings County, where we had a strong emphasis on ultrasound. We used ultrasound for really everything that we did, every critically ill patient, and even patients that weren't so critical. But when I went off to do fellowship, it was more of a traditional type setting, where we didn't have ultrasound on the floors. And I would respond to codes, and one particular code that I went to was a 50-year-old gentleman who was coding. No one really knew much about them, but what they knew is that they knew they had the ACLS card and they were following along intently. So they knew that much, but no one really knew about this patient. So this guy's been coding now for 20, 25 minutes, and I ask for the ultrasound machine, and someone runs out and gets it, and 10 minutes later, the machine comes into the room, and this is what we get. 35, 40 minutes in the code, no perfusion to the brain, and now, at this point, we decide the bright idea would be to stick a needle into the chest. I couldn't believe it. We got return of spontaneous circulation back on this guy, but I took care of him for the next week. He did not have a good neurologic outcome. And every day rounding on this guy, I felt so guilty that we could have found out what was causing this cardiac arrest early on and got perfusion back. So it really just reminded me how much further we have to go with cardiac arrest, even though we think we're great. So running a code with a probe in hand, I have no disclosures to make, but I want to give you the layout of where we're going today. The first thing is we really have to reevaluate this pulse check that we do during cardiac arrest. Is it time for a reboot? Do we need to do something a little bit differently? I think we do. Does ultrasound help us to prognosticate? And many of you are very familiar with the literature, but we're just going to highlight what you already know. We're looking for reversible causes. That's really the name of the game here. We want to be sure that we find out what's causing that cardiac arrest the first pulse check, and we reverse that so we get perfusion back for this person. You don't want to be taking care of that person who had sacrificed perfusion to the brain for 45 minutes. You'd feel guilty. And is there a better way of doing all of this? And I'll show you an alternative way that you can use ultrasound for those patients who are in arrest. So let's talk a little bit about the pulse, Pulse 2.0. Now, we've been doing closed chest compressions for a long time now, like 50 years. And if you look at it, they used to open up the heart, and they used to put the hand, and they used to squeeze. Things have changed. We're doing closed chest compressions. The question I ask you, though, is 50 years later, are we doing anything differently? Where are we at 2015? I actually think we're doing a lot of good things. We know that we have to push hard, push fast, right? That's a good thing, right? Get the perfusion going, keep your hands on the chest as much as you can. We know that we need to use electricity, biphasic defibrillation. We need to know when we have a shockable rhythm, shock early, and then get back on the chest and compress. We know that we have lots of tools that we have at the bedside. We have monitors. We even have monitors now that can interpret the rhythm as we're doing chest compressions. Really cool stuff. And we're using end-tidal as part of our resuscitation. We're doing really good stuff with resuscitation 50 years later. And then when it comes time to check the fruits of your labor, to check that pulse check, to see what you have done for those couple minutes when you're doing a resuscitation, what are the most sophisticated tools that we have at the bedside to check? Your fingers? Are you kidding me? With all this technology, all we have is our fingers? If you listen to the ED ECMO podcast, Joe Beleza refers to this as the digitometer. You know, you rely on your digitometer. We can go through the data and talk about how poor the pulse check is. But in short, people can't detect the pulse very accurately. So feel a pulse, not sure if it's there. How long does it take to accurately detect the pulse? And then even worse so is that there's some literature that suggests that people palpate a pulse, or they think they palpate a pulse, and there's no pulse there at all. So that means that person's not getting chest compressions. That's terrible. We can do much better than that. This is a big problem too. How are you going to palpate the pulse on this person? Even if there is a pulse that's palpable, I'm not sure you're going to find it. And I've personally been part of arrests where I'm going to intubate somebody, and the person grabs my hand and says, "Don't do that." I mean, they were just taking a nap. And I'm sitting there trying to resuscitate and intubate them. Don't be that person. So I think it's time for a reboot. We need a do-over. We need to figure out how to do this pulse check better. We need to get away from using the digitometer and do what we know how to do best. I mean, we are masters of ultrasound, and we got to use this at the bedside for every pulse check. Because both these patients that you see on the screen here, the one on the left and the right, neither of them had a pulse. You could make the argument that maybe the person on the right, we just couldn't palpate it because our fingers are not sensitive enough. Maybe their systolic blood pressure was 50, just under the detectable range of our fingers. But the person on the right has a pretty good prognosis. The person on the left, maybe not so much. and we have to do things very differently. But you would never know this unless you had the ultrasound at the bedside. So maybe it's time we update this all, replace the pulse check with an ultrasound check. The next thing I want to talk about is the prognosis. And again, just a brief review, but for patients, and specifically we're talking about patients with out-of-hospital cardiac arrest. What can we do for these peeps? This is the video I showed you before. Look at all the people that are in the room. How many of you have cardiac arrest where so many people swarm the room? We all have that? What's happening to the rest of the patients in the department? Who's seeing them? I mean, look what we have here. We have the person who's running the code. We have the person doing the chest compressions. We have the charge nurse running the meds. We have someone putting in an A-line, and we have the respiratory therapist. Look at all the other people that are just standing there. I mean, they want to help. They mean well. It's not that they're lazy, but there's nothing for them to do there. Now, if you work in a place that has a lot of money and you can do this, then by all means, get as many people as you can, shoehorn them in that room if you want to run a resuscitation that way. At my shop, after I'm done with a 2-hour code and I go to the waiting room, it kind of looks like this. Really does. So I can't do that. I can't be resuscitating every single person that comes in pulseless. If there was only a way I can determine who's not going to have a good outcome and who I should be continuing this resuscitation with. Back in 2001, Mike Blavis put out a study where he said if you come in the hospital, out of hospital cardiac arrest, and this ultrasound right here, which is cardiac standstill, there's no movement of these ventricles, your prognosis was 0. You're not leaving that hospital alive. 0%. Now, there have been some studies since then, and some nerdy statisticians have come along and say, whoa, 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 0%? You're so negative. It's 2.4%. Much better odds. And the asterisk is there because this is a meta-analysis. We don't know what the neurologic outcome really is. So maybe those people did get their pulse back, but we don't know if they left the hospital alive and neurologically intact. It does help us to decide. If you have somebody who's young with a reversible disease and you put that probe on and you see cardiac activity, then by all means keep going. But if you have someone who's elderly, comorbidities, they've been down for a while before they came to the hospital and there's cardiac standstill, I don't think there's any need to keep going. Stop by using your ultrasound. Show the family that there's cardiac standstill and put your resources back into the other ill people who are in your department that need to be seen. Now, the good news is there's a trial called the Reason 1 trial that's going on now that's going to help answer these questions. They're going to be answering the neurologically outcome. So we'll wait and see what happens with this study. But just use ultrasound right now as a way to prognosticate your patients. Now, we're going to spend a fair bit of time talking about reversible causes because that's really what we're about. We want to get this person back to perfusion because it's all about the brain. Everything we're doing with CPR is about getting perfusion back to the brain. Sure, it's about the heart and the kidneys and the guts and all that stuff, but it's really about brain perfusion because if that person gets return spontaneous circulation, but they're not thinking right, what's it all for? Now, ACLS gets a bad rap for a couple reasons, but I'll tell you, it's pretty good in a lot of ways. It helps us to, stratify what we're going to do for our patients. So if you have someone who's bradycardic, what do? Right? You pace them, you give them atropine, you get that heart rate up. Simple. If you have somebody who's tachycardic and has a shockable rhythm, well, by all means, shock them, get that rhythm back to normal. If you have someone, say, systolic, well, give them epi, push as hard as you can, push fast, do what you can. But what about this? What about PEA? It really is kind of a troubling term. PEA, pulseless electrical activity, what do we do with that? It used to be called electromechanical dissociation, and what that meant was you'd have an electrical activity on the monitor, but there was nothing mechanically happening with the heart. In the 1990s, this term got changed around to pulseless electrical activity because people were using ultrasound at the bedside, and what they found was there'd be electrical activity, but there would be some sort of contraction. If you look up here on the screen, you see a parasternal, long axis view, and that left ventricle, it's working, just not very well. It can't generate that kick, that pulse that you'd palpate. If you go to look at a pulse check, this person did not have a palpable pulse, but with ultrasound, with Doppler, you see this carotid pulse right here. Seemingly there's flow, just not enough flow. And this is assuming that the fingers are good enough. I'm giving our digitometer some credit, okay? So assume that your digitometers are great. This pulse is there, it's just not good enough. But this is all categorized as PEA. So then there was a movement to change it from true PEA, which is really like electromechanical dissociation, into something known as pseudo-PEA, right? And how are you going to tell the difference between those two? How are you going to tell the difference between both these patients? True PEA, pseudo PEA, how are you going to do at the bedside? What would ACLS do? Oh, that's right, the H's and the T's, right? That always bails us out. All right, you guys remember the H's and T's. Hypoxia, hypovolemia. Is it hypothermia? Do they have too much or too little potassium? Is it too much acidosis? Hydrogen ions. Or is it things like toxins, trauma? Is it a massive MI or a massive PE? Is it pericardial tamponade or tension pneumothorax? How are you going to discern between these two with this one ubiquitous term of PEA? Well, let's go through it and see. If the person's hypoxemic, it's easy to throw oxygen on. Check. If the person has some toxin on board and you know what it is, you can try and find the antidote. If you don't know, just give them bicarb or Narcan. That's a reversal agent. You could touch your patient and see if they're cold. That would be something you could do at the bedside. Acidosis, you can give them bicarb if you believe in it. You can give them calcium and bicarb if it's a potassium issue. But what's left? What's left after you ruled out all those things? You have these things right here. And how are you going to tell the difference between the differentials of these? Each one of these is treated very, very differently. But on the card, it's part of the H's and the T's. It's giving epi, push, and think about and consider these diagnoses. How are you going to consider them? You're going to trust your digitometers? Maybe you have some secret Jedi trick that no one else knows in your bag of tricks, right? Magic 8-ball you shake up. Maybe it's tamponade, guys. Shake it up. You got to use ultrasound and find the reversible cause, because every minute that goes by where you don't know what's going on and that person's not getting perfusion to the brain, their mortality is going up and up and up. And you got to use ultrasound every single time. Let me give you some cases that either I had or my friends have sent me, because I think this really drives home the point. This was a case I saw last year of a 45-year-old female who just collapsed at a party. No history, just collapsed at a party. And the first pulse check, we did a parasternal long axis view, which you're seeing here. Believe me, that's actually a heart in there. And we found standstill. But she was young, and we said we'd really look for a reversible cause. You see in here the green, there's the heart. All around there is a pericardial effusion. This is blood that's clotted. She had a type A dissection. She died. But we did a pericardiocentesis at the next pulse check, and I think we gave her the best shot that we possibly could have from this devastating illness. Here's another case, a little less subtle. Here you see pericardial effusion. This is tamponade. Find this early and drain it. This case, person comes in cardiogenic shock. You can't palpate a pulse, but clearly there's some activity there. Maybe this person needs some inotropes and some vasopressors. Maybe that's the way you resuscitate this person, not pushing on their chest and pushing 1,000 micrograms of epi. Maybe they need 10 micrograms or 20 micrograms of epinephrine. Oh, here's a classic story. Person gets off a transatlantic flight, they're a smoker on oral contraceptive pills. They come into you and they're in arrest. We all debate whether or not we should push TPA right off the bat. Right? We just hate to be wrong. But by having ultrasound ready, this empowers you to make the right decision. This is an actual case. This is the right ventricle right here, big, swollen, dilated. It's not moving. And look at the underfilled LV. This person got TPA push, but we felt confident about it in arrest, pushing it, and we did it for the right indication. If you have the chance, look at the lower extremity veins. Here's the femoral vein. There's a clot just bouncing around in there. So ultrasound really gives you the ammunition you need to move on and do the right things for your patient. This is a person who's post-VFib. They got shocked. This is the ultrasound you see. You see wall motion abnormality right there. This person goes up to the cath lab. Now the good news is, it's not all about medical arrests. You can use this for virtually any arrest that you have, anything where you're looking for reversible causes. Take trauma, for example. Here's a person that was stabbed in the sort of nipple zone, not really knowing what's going on, gets hypotensive and codes in the department. This is the diaphragm right here. To the right of the diaphragm, you see the liver, or the spleen if you're on the left side, and over there, that's all the lung that's left, this little nubbin of lung, and all that black anechoic space is all blood, hypotensive or blood. You know right then and there. Yes, you could put a chest tube in, you can do finger thoracoscopies. I'm not here to tell you delay things that you know how to do with ultrasound, but in the undifferentiated case, you have something that tilts you in the right direction as part of your initial exam. Fast exam, you've all seen that before, free fluid. I'm not getting chest x-rays for my patients as they're coding. It's much easier to get ultrasound. And you tell me, which side has the pneumothorax, right or left? Say it louder. Left. The left side has the pneumothorax. You know this during your code. Just decompress that side. Elderly male comes in, cold and clammy, collapses in your ED. AAA. Resuscitate him, call the surgeons, he goes upstairs. So this term PEA, this broad net that really encapsulates so many different diseases that are treated so differently, should we really just get rid of the term altogether in the ACLS algorithm? Should one term really fit everything that we do, this PEA, this wastebasket term? Because I'd argue that both these cases shouldn't be managed the same. Again, you can do the chest compressions and a milligram of epinephrine for the person on the left because things aren't looking good. And you can try and figure out the other H's and the T's that you can reverse. But for the person on the right, I would give them inotropes, I'd give them the vasopressors, I'd put an A-line in. I'd see if this person actually had a blood pressure that I just couldn't feel. And it's not really pulseless. There's just a pulse that's very, very low. So I think it's time for a paradigm shift. And the best one that I've heard so far has been one by this guy, Scott Weingart. You heard of him? He came up with a term called prem and press. Actually, I'm not sure if he did, but I'm giving him credit for it because I heard it from him first. It's really a unique term, and it encapsulates ultrasound in all of your arrests. So if you're talking about prem, we're talking about pulseless with an electrical rhythm and echo motion. That would be the pseudo-PEA. And that's this case right here. So parasternal long axis view, parasternal short axis view, this heart squeezing just not good enough. This person got small aliquots of epinephrine and increased their inotropy and got their pulse back. Treat it like shock. Treat this person like shock. They have a reversible cause. You see what the problem is, augment their contractility of their heart. Here's another case that my friend sent me, Sam Ghali. This is an RV that's not working very well. And rather than slugging him with epinephrine and pushing on the chest because they couldn't feel a pulse, they give little aliquots of epinephrine, and look what happened. That RV is squeezing a lot better. And that left ventricle that you see on the left side that's collapsed and slit-like because it's not getting blood flow from the right side is now filling up with blood and getting systemic perfusion. So it's really a different way of thinking. It's almost like a culture shift, if you will. And then there's press, which is pulseless with the rhythm and echo standstill. And that's just very simply this. And you can call this true PA, you can call it asystole. For this, you can go down the algorithm, consider other things. But we kind of know where this person is headed. So do your best for this person, but perhaps treat it exactly the same way as true PA, but the names here are just semantics. So that's the reversibility, really the crux of what we want to do when we're resuscitating not only cardiac arrest patients, any patients who are sick. We want to find the reversible causes and get perfusion back to where it needs to be. The last thing I want to talk about is maybe there's a better way of doing all of this. Now, anyone that knows me or has worked with me knows that I love transthoracic echocardiography. If I have an ultrasound machine and you're staying close enough to me, you're getting an ultrasound, whether you need it or not. I just love it. It's the greatest thing in the world. But I'll be the first one to admit to you that image quality is not always optimal. And certainly, Dr. Dawson told you to shift people on their side, and that's a good thing to do if you have a cooperative patient. You know, what if you have someone in arrest? It's kind of hard to do chest compressions while tilting them on the left lateral decubitus. So the other problem is that we have these patients. Again, where are you going to get your image? You know, we like to do subxiphoid views, but this is going to be a really challenging one to get. Also, with the amount of tissue that they have in their anterior chest, it might be hard to get an image of their parasternal long axis view or their apical views as well. Even people who are young and healthy realize you have to scan through a lot of tissue, skin, subcutaneous tissue, muscles, fat, lung, and then you have to fit that probe through a tiny rib window to get your image. So it's not always easy, especially during arrest. And then you got people yelling at you. 10 seconds, pulse check should be 10 seconds, right? We know we got to get back on the chest and compress. So you got to get your window quickly, and you only got 10 seconds to do it. So the solution is actually a phrase that was out for a very long time, but no one ever put it together, right? The best way to someone's heart is through their stomach. It's actually their esophagus. Transesophageal echocardiography, that's the way to go. And if you haven't seen this before, this is basically ultrasound on a stick, I've heard it referred to. And there are crystals that are up here in the probe, and this whole thing goes into the esophagus, and use these controls on the outside to manipulate the beam rotation, and then you can use these dials over here to flex and extend the probe. And you can get virtually any image you want by using transesophageal echo. So if the probe is going down into the esophagus and the beams are facing out to this way, and this beam is facing you, you can turn this thing called the omniplane, and you can rotate this beam any way you want. It's really neat in 100 degrees of plane. Look at this cartoon over here, and you'll get a good example. That sector, that yellow that you're seeing there, is what's going through the heart. And instead of going through lungs, ribs, subcutaneous tissues, now you're only going 2 or 3 millimeters, and you're right into the heart. And the images are beautiful. The probes are getting so small, they're the size of an NG tube. You can pop these in now at the beginning of arrest and leave the image up on the screen and watch it, and you can shock through all these. But this is how small the probes are getting, just to be the size of an NG tube. I truly believe emergency medicine will be doing TEE in academic centers within the next 5 to 10 years, and places are already doing it. So if we show you this mid-esophageal view, mid-esophagus, the beams are shooting behind the heart, let's see what we find. Look how beautiful these images are. And these are not hard to obtain. The hardest thing is getting the probe inside the esophagus, and it's not that hard. We put NG tubes in all the time. This is a big NG tube. And look at the images you're getting. So this is like an apical 4-chamber view, just like a mirror image of it. Here I'm showing you that the 0 plane, we're at the 0 plane of that omniplane. And this is all you need for an arrest, this one view. Left ventricle, right atrium, left atrium. If you rotate that omniplane a little bit, 120, 130 degrees, you get this image. This almost looks like a parasternal long axis view here. We see the left ventricle. We see the right ventricular outflow tract. And we see the valves. You can go a little deeper if you want to into the stomach and look back at the heart. This is called a deep gastric view. And what you see here looks like a parasternal short axis view. You see the left ventricle, and here you see the right ventricle. In this case, a big vegetation that's flopping around that right ventricle. So you see how good the images are, and believe me, I'm not trying to pull one over on you, and this is not like an expert level thing. TE is probably the easiest thing that you can do. It's just for whatever reason, the anesthesiologist, the cardiologist don't want us to do it. We'll talk about that in just a moment. The pulse check, can this help us for a pulse check? Well, remember, when you're doing a pulse check with transthoracic echo, people are waiting on you. They want to get back to compressing, and you're trying to find your window. With TEE, the minute the compressions stop, you got the images on the screen. 1, 2 seconds, you know if there's motion or not. You can find the reversible causes. You can find the reversible causes as people are doing chest compressions. What could be better? The next thing is really, really cool. Are we doing chest compressions right? So you can push on the chest and say you're doing something, but are we really doing anything? And this was introduced to me by Dr. Mike Mallon. It's a really novel concept. I guess I should give Matt Dawson some credit too, who's on the ultrasound podcast. I'll give it to you. You get partial credit. Look at this heart right here. So someone's doing chest compressions with the TE probe in. The right ventricle, which if you're looking at the right screen over here, I'll show you, the right ventricle looks like it's compressing. The left ventricle, meh. Look what happens if you tell your people who are doing chest compressions, move your hands around, move it a little down, move it off to the side. Look at the chest compressions now. We're getting RV and LV contraction. You're doing a goal-directed chest compression. It's awesome. So not all chest compressions are equal. Which one would you rather have? Here's another one from my buddy Rob Arnfield. Look how good these chest compressions are. You can actually tell your techs or whoever's doing the chest compressions what they need to do to make things better. How about depth? We all know that we have to go at a depth of 5 centimeters. That's recommended. I don't have a tape measure in my ED. I don't think I would measure even if I did. So can we use TE to help us? And it turns out we can. If you take M mode, which is basically a cursor, taking all the ultrasound pixels down in one line, and so right here we're taking all those pixels. What you have in the forescreen, or closer to the surface here, is the left ventricle, and then distal you have the right ventricle, and the very bottom part of the screen is the sternum. And look what happens when you watch the sternum over time. So you watch the sternum going with chest compressions, you run the M mode, and then you can actually see how far the excursion of that sternum is. And this one is 2.8 centimeters. You tell your team, you got to push harder. They start pushing harder. You do M mode again. You watch the sternum go up and down for a couple of cycles. You run your M mode, and what do you find? You find this time it's 4.9 centimeters. You're pushing it real good. Keep doing what you're doing. Thought you'd like that. So what are the complications, the big things? Oh, wait a minute. You mean we're going to have to shove this garden hose down someone's throat? Oh, what if we cause esophageal perforation? How many things do we do on our shifts that are just, you tell your friends what you do and they're just like, that is bizarre. All the complications we can have, procedural sedation, intubation, chest tubes, crack in the chest, pericardiocentesis. We do things with a lot of complications. So esophageal perforation, when you scour the literature, 0.3% complication rate of esophageal perforation. And that would be the biggest risk that you worry about, the biggest complication. So there really should be no fear for any of this. So TE, it's coming to an academic center near you, and it may come to the community as well. Now, I've been talking a lot about ultrasound, and I don't want to sound like I'm speaking from an ivory tower and you got to use ultrasound. Let me give you some tips on how I think you can make ultrasound a better part of your code today. Remember, it's all about balancing, finding that reversible cause, and getting perfusion back as quick as you can. So here's the tips I got for you. Now, I teach in an academic center. I love teaching medical students and residents, but when it comes to the pulse check, using ultrasound, the best person in the room should be doing the pulse check. The best person in the room, because it takes time to find that image, and you want to get your pulse check done in under 10 seconds. So don't let the medical student who's like, hey, you've never done ultrasound before? Well, let's see if you can find the heart. That is not the time to do teaching. There's a time and a place. Who should do it? Rock stars should do it. Like that guy. That's actually Dawson. I don't know if you saw under his shirt. He cleans up nice, but he's got a lot of tats. But the rock stars, the attendings that can do it, fellows, if you're an attending and your resident can do it better, let the resident do it. But the best person in the room should do that because you have a limited amount of time to get high quality images. The next tip I suggest is you get your code leader to remember to count down the pulse check. This is a really good tip regardless if you're using ultrasound or not, but have the person who's running the code count down 10, 9, 8, 7. This lets everyone know in the room that it's a pulse check and how much time they have, but it lets the person doing the ultrasound know that they better wrap things up because we're going to get back to chest compressions, and you got to push that person off the chest and get back to chest compressions. The next thing is a little bit of a pet peeve of mine that I sometimes see is that people getting ultrasounds of VFib. Now, if you don't know if the VFib is a coarse VFib or a very fine VFib, you need ultrasound, then maybe. But if you see VFib, this just needs to be shocked. You shouldn't be getting images of VFib just for the sake of getting it. You're delaying the time that that person has to get the electricity and chest compression, so don't do it. Subxiphoid view, I'm not really a big fan of it during cardiac arrest. I'm much more of a parasternal long axis view. There's less tissue to go through, it's much faster. Second and fifth intercostal space, I won't repeat with what Matt said. He went over it really well, but look how good the images are, and look how much closer to the chest, to the surface of the skin it is. Finally, ultrasound hypnosis, and this happens sometimes when you're doing ultrasound. You're there, you're interpreting. I'm guilty of it all the time, and people are like, we gotta go. It's like, just one more second. This is it. I'm gonna figure it out. Don't get hypnotized by the screen. Instead, get your image and just keep saving clips. Save, 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 save. Don't even interpret. Save, save, save. And then while the next round of compressions are going, go back and interpret the image and tell your team leader, listen, I found a pericardial effusion. Great, next pulse check, we're going to go drain that. Don't waste time with interpreting images. And then have a towel nearby because you want to be sure that the person gets back on the chest and has good friction on the chest. You don't want them sliding around as they're trying to get back to chest compression. So wipe that person down really well. So remember, no newbies. Count down your pulse checks. Don't ultrasound VFib unless you're unsure if it's VFib. Go for the parasternal long axis view. Just take clips, don't interpret, and then wipe that patient down. So we're running short on time. Are there any questions?